Zabta Shinwari, and it's always pleasing to be at the Pakistan Academies of Sciences, now being a fellow. It's a privilege and an honor, and it's great to see some good audience after a long time. It's been a break just because of COVID. We all know we are in a big challenge, and it's our duty not only to come out of the challenge, but see the gaps, fill in those gaps, plug those gaps, and see the future. So with all that, without wasting much of time, I'm equally grateful to all the participants and the panelists in this group. And good to see Dr. Zulfikar Bhutta there as well, and Nancy, seeing you after a long time. So we'll start off the session without wasting a moment from now on, and I would be calling Professor Dariush Fahad from the School of Public Health, Tehran, University of Medical Sciences of Iran, and he's basically Professor of Medical and Clinical Genetics. And we'll be talking about fight against viruses, COVID, peace among nations. So over to you. I think a little bit of time, so we'll wait for him. But meanwhile, Professor Zulfikar Bhutta, I'm going to bother you now for your presentation on COVID-19 and priorities for research and development findings from a PS roundtable. And I think Dr. Zulfikar Bhutta's name, all of you online must be knowing already. Great passionate for the country. Previously with Aga Khan, now in Canada, still working for Aga Khan. And let me share yet another honor that he has been bestowed. He is the new chair of the board of directors of National Institute of Health. So all the things coming down from Pakistan Academy of Sciences, and will be going down as a fellow of Pakistan Academy of Sciences, will be translated into real research at NIH, because PHRC is also coming down at NIH. So that's a great passion that he's coming down all the way, bothered about such things in the country, back home, and we expect much more to come from his side. So over to you, Professor Bhutta.
Thank you very much. I just want to be sure that you can hear me and see my screen.
Yes, please, loud and clear.
All right, wonderful. Well, it's always a pleasure to be part of the Academy, and I'm grateful for the opportunity to see you this morning. I have been asked to speak about the roundtable that we had organized at Pakistan Academy of Sciences a few months ago, right at the very beginning of the third wave, way back in February. And the idea at that time was to principally bring together a body of scientists working on COVID-19 in the country with some leading policymakers in an effort to review what had happened the last year, what were the lessons and opportunities for research and development. What I would like to cover in the next 15-20 minutes or so is a little bit about the background. Why did we hold that workshop? Why did we cover various aspects, the three aspects of the agenda? What was the general feedback from the participants? It was an invitation-only roundtable restricted to about 35 participants, and then talk a little bit about what were the major conclusions. So, ladies and gentlemen, it's amazing as we speak about the pandemic today. These are data from last night. Around 167 million cases officially about the COVID-19 infection so far, and close to around 3.5 million deaths. And if you were to believe the Institute of Health Metrics and Evaluation in terms of their own recent assessment of the pandemic, that these deaths are probably vastly undercounted. And from their estimates, in comparison, what Chris Murray and colleagues will have us believe is that these could be underestimated by a factor of 2, that we are possibly dealing with close to around 7 million deaths globally. And I know that the World Health Organization has also corroborated some of these estimates in terms of both excess mortality, both direct and indirect from COVID-19. So it's been a massive, massive global upheaval which has turned lifestyles and everything upside down. The reason why we wanted to focus on this in our workshop that we held a few months ago was because it affected Pakistan almost from the very get-go. We were amongst the first countries to respond to the pandemic. There were travelers who were coming from Iran, from Pakistan, and also because of the initial risk of infection given our proximity to some of the early places of outbreak. So, Iran, and of course we share a border with China. There were enormous problems at the time when the pandemic started. Healthcare system was totally unprepared for something of this nature and consequences. It shut down the economy immediately, given the government's stringent response, particularly in several provinces, which was the economic hub of the country. And our schools have been virtually closed since that time. And even now, they've only been intermittent to be open, and we face a huge challenge in terms of the entire academic year for many children in the region. And this is not different from many other places. Here in North America, it's been a similar situation also in many places. There were many challenges in addition to what I've just mentioned, and Amar is sitting at the podium, and he was charged with evaluating what would be the response in terms of diagnostics. And I'll speak a little bit about that in a minute. In addition to testing, contact tracing, what could we do in terms of identifying people and how, using technology that was in hand, establishing centers of excellence and self-reliance and things like personal protection equipment manufacturing. At the time when this pandemic started, had almost entirely been imported. There were other challenges that were beginning to emerge, such as the variants, and by the time we held this workshop at roundtable at the PAS a few months ago, variants had already begun to raise their head in the region, but they had significantly impacted disease burden in other parts of the world, such as United Kingdom, Brazil, South Africa, and certainly for variants, testing capacity is universal. And therefore, nationally, we had to create and work through in terms of how we could develop public-private partnerships that I will speak about shortly. We had earmarked some money for research, and although most of those funds were to the Higher Education Commission or the Ministry of Science and Technology, it wasn't very clear how that money had been spent and what was the result of having our health sector research come forward. And that was the reason why the Academy of Sciences and the Other Country University collaborated in bringing science together. We were very grateful for a large number of very eminent speakers that are listed on this. We had the presence of Dr. Faisal Sultan, the Special Assistant to the Prime Minister, who shared his thoughts with us, and Professor Tawar Rahman, who is Chairman of the Prime Minister's Task Force for COVID, the Ministry of Science and Technology. But we also heard from many others, including our worthy chair. There were many others that we benefited from their inputs. And as I said, this was an invitation-only roundtable, but this list represents almost all the eminent people who have been working on various aspects of this pandemic in the country. So in Pakistan, of course, at the time when we met, we had conducted around 8 million tests. There are a lot more. And with a positivity rate of about 0.5 million cases, with a recovery rate of about 92% from the pandemic per state. We noted that the peak of the pandemic last year was around June, and a second wave was encountered around December. And we discussed a fair number of challenges at that time, even before the enormity of the third wave in the region was recognized. This slide shows you, to a large extent, the extent of the pandemic in the country over this period of time, right up to the 24th of May 2021. So, as you can see, we clearly have had the third wave. We are not 100% certain that we are out of it yet, particularly because the isolation rates or the presence of the double variant from India has not yet been confirmed, so we are not entirely sure we are over the crisis. But as you can see, this pandemic has taken its toll, and particularly over the last 6 months, this has been quite an uphill battle getting it down, because the corresponding response in terms of mitigation strategies in the countries has been uneven, particularly the use of face masks and social distancing. This slide shows you the trends of daily tests and positive cases, and as you can see overall, we've had a significant upsurge in the third wave, but we also have been able to maintain a testing rate overall, which has been around 40,000 or thereabouts cases per day. If you look at positivity rate, we are not as high as we were at the peak of the pandemic last year, where compared to the test performed per se, we had positivity rates of around 20% or thereabouts. Today, as we speak, our positivity rates vary, but on an average, work out at close to around 5% nationally. There are some cities where the positivity rates are higher. This is a comparison of positivity rates by week across provinces. You can see the upsurge, and you can see that it's stayed above 10% in many large cities. And this is also shown in these slides that have been shared from the most recent SBFC presentation. So these are cities of the province of Punjab. Large cities with large populations, Faisalabad in particular, you will see has a positivity rate of about 6%. But there are many which have positivity rates north of 11%. Other cities, Lahore, around 8%, as you can see here. So, fairly significant upsurge in many places. In the city where you are, Islamabad, close to it, the twin city of Rawalpindi, positivity rates of close to around 15%. And this region has also had quite a large proportion of testing. In Khyber Pakhtunkhwa, in the very northern province, positivity rates in many cities have also been around 5, 8, as high as 13% in the city of Makkah. In Sindh, the province where I do most of my work, in the big mega city of Karachi and Hyderabad, positivity rates have been between 11 and 14%. So at the time when the roundtable took place and the analysis of the situation, several points were made in terms of what we had learned in training and what were the issues that we were dealing with. One was that we really did not have a public health surveillance system which was uniform and homogeneous. And Ahmed can speak about that when he does comment. The public health surveillance system was fragmented. The National Institute of Health has tried to do its level best in terms of setting up an infectious disease surveillance system, but this is something that the country really needs. And it wasn't prepared for outbreaks of novel pathogens. The COVID-19 SARS-CoV-2 outbreak was one of the first times that we have had a respiratory pathogen of this nature with such rapid transmission that had pressure tested the system. The reporting system had to be set up brand new, and the government at a very early stage, with full credit to the NCOT and the Ministry of Health Service Regulation, established a brand new surveillance system to get a sense of what was happening to morbidity and mortality. And thank God for that, because we do have the statistics where we would have had nothing coming in from a mortality surveillance. We had very few people that we could rely upon for provision of health services within the health system. And even if we had a few people in big cities, in the smaller towns, etc., there were hardly any people trained to provide intensive care. So a brand new system of virtual learning and training had to be established through a collaboration between the Ministry of Science, the Ministry of Health, the Health Services Academy, and the Aga Khan University. There were also major points brought forward in our situational analysis at that time that related to limited information on immunology in terms of what the background rates for immune response, serologies, serotesting in the country were, and a few serological surveys have done, and very few indeed have been done serially looking at cohorts in terms of what has changed. But we do have information now from a serial survey that we've been partnering with the National Institute of Health from Sindh, showing for the first time in a cohort that seropositivity rates have gone up from about 20% to around 50% in major metropolitan areas of Sindh. Modeling was a major exercise, something that I was involved in also with the government, predicting where this pandemic would go. And I must say that after a year and a half almost of looking at this, modeling is again something that the global community needs to invest in, because we've been wrong more often than not in terms of predicting how the pandemic would respond and behave, and no one had predicted what would happen when you had variants of interest in terms of R0 and disease patterns. So there is a fair amount of learning around how these models will behave in different parts of the world. I mentioned that there was some research funding provided from the Higher Education Commission. We launched a Rapid Research and Innovation Fund, and since I chair that particular committee of the Health and Allied Sciences at Higher Education Commission, I had a pole position in terms of looking at where that money could go and who applied and what the quality of those proposals. So that's not to say that money wasn't there. We made that money available through rapid research grants, rapid technology transfer grants, which offered close to around 15 million to 7.5 million rupees for 6 to 12 months to research organizations. But it's fair to say that in general, the quality of the research proposals that we received through that portal was very poor. And it also reflected to some extent lack of capacity in many institutions to implement that research. So quickly on testing, as I said, there was tremendous variability, and Lapta mentioned the inequity and disparities. This, to a certain extent, also reflects disparity in testing capacities and ability in various parts of the country. Islamabad, because it also has centralized testing for many travelers, Health and National Institute of Health has been able to do close to around 700,000 tests per million population. But the rest of the country is averaged around, I would say, around 40,000 tests per million population. And as you can see, again, to the credit of the National Institute of Health, has been able, despite the fluctuation, has been able to maintain a fairly steady stream of uniform testing across the country. And most of these are PCR tests, not rapid tests or any other shortcuts. The government science response can be divided into two parts, and this was shared in our roundtable. The Ministry of Science and Technology focused its attention on giving grants and creating some centers of excellence for testing for viral variants in genomics, and some of those funds were spent in various provinces, including Sudan, where they established an institute for doing this. They also focused their attention on clinical trials, but most of these related to testing of various formulations and medications, and they were overseen by many WHO collaborators. There were some efforts earlier on for developing indigenous ventilators and rapid testing, and I'd be happy to answer questions on this, because I don't think this was very successful, because none of these have been at a scale that one would say we have commercial availability. Digital innovation, however, was enormously successful. I think full credit again to the early response from the NCOC, that this was a platform that was established very rapidly, and that's the reason why I can show you some of these data from yesterday in terms of the national surveillance system that was set, or the contact tracing system that was set using some of the technology at hand, and our ability to collate data. The Ministry of Science and Technology also invested in some biotechnology parts with public-private partnership for indigenous production of supplies and consumables. This has not been evaluated yet, so I'm not in a position to say whether this will be successful in terms of scaling up, but we are at least self-sufficient now, more than a year into the pandemic, in indigenous supply of personalized protection equipment. What about the National Institute of Health? And we have the executive director in our midst. The NIA, I believe, did a stellar job. It established very early on a disease control center for looking at COVID-19, and it will also, in the future, be looking at all of this in addition to the CDC within the National Institute of Health, but also to a National Health Research Agency, which will be able to streamline this. But the greatest credit to the National Institute of Health has been really established from the network of testing across the country and in providing an opportunity for real-time quality assurance of many of these testing centers through its centralized quality assurance scheme for looking at the quality of these surveillance in various provinces. And that, I believe, is a huge credit to an institute at the time of national. We have data, as I said, the innovation, digital innovation allowed us to look at this. These are some of these stats over this period of time. As you can see, these mortality rates have seen a high of as much as 100 deaths per day. Even if you believe that these are an overestimate, an underestimate, the 20,000 deaths or so that we have had so far, and you multiply them by the factor that IFME is suggesting, you still end up with nowhere near close to the mortality that some countries have. And it's actually a research subject of interest to many academics. Why has that been the case, especially when mitigation strategies such as face mask use and those sorts of things have been so rare. I don't believe in our culture that you can hide death, just like people were not able to hide death in North India. We have not, thank God, fortunately seen any mass graves or any mass burials of the kind that you witness when your mortality goes out of hand. But that's what, we're at an early stage yet. We should be able to declare victory at some stage, but this gives you a spread of the mortality. Most of the deaths have been in the elderly population, not in the extreme elderly because of our population pyramid, which is different. There has been a very interesting and to me a puzzling male predominance in this. And at some stage we will be able to evaluate why there has been such a gender disparity in terms of mortality. And this, as I said, is not just because of underreporting or the fact that there isn't care seeking amongst women. But there has been a gender differential, which has been also notable in other countries in terms of deaths. So this may represent maybe differences between provinces also. When you look at the disease pyramid, about 79% of the cases were above 50 years of age overall, but three-quarters of cases are below 50 years of age, but 79% of the deaths are above 50 years of age. So you can see the disparity very clearly in relation to the population pyramid. There are many deaths in hospital, but there are also deaths at home, which the surveillance system picks up. The ratio currently is close to around 1:1 or 1:1.5 in many big cities. But as I said, some of these could be an underestimate with an underreporting of deaths in many or misclassification in many circumstances. And finally, this is the age pyramid of mortality. I keep telling my pediatrician colleagues, I'm a pediatrician myself, that we have had quite a significant proportion of deaths, even though they have been vanishingly small elsewhere in children between 0 to 20 years of age. There were a number of feedbacks from the participants that I will not go through this in terms of what needed to be done, but I want to conclude by telling you what the roundtable arrived at. So first was a very, very clear underscoring of the need for strengthening of national capacities for surveillance and monitoring. And people underscored the role that the National Institutes of Health play in infectious disease surveillance and monitoring. I'd like to hear more about this in terms of the Institute's plan. It was underscored that this was not the first and the last pandemic that we would be addressing, and that there was an absolutely urgent need for development of a national strategy or an active plan to deal with such outbreaks. We also underscored that at the time of need, certainly for training of healthcare professionals and for higher diagnostics, the country had seen very important close collaboration with the public-private sectors, researchers and academia, and this should continue as a model in terms of strengthening research, monitoring and evaluation in the future. It was recognized that we needed to do much better in terms of our higher centers of learning, our universities and colleges, in terms of supporting their research environment And if the quality of research proposals and research in these areas of infectious disease was to improve, then this cannot just happen in a pandemic. That we need to make this as part of the learning culture of these academic centers and to provide opportunities for strengthening infectious disease research in general. Vaccines, I hope somebody will understand this, and I see our colleagues from China. We are extremely grateful for the support that we've received so far in both vaccine deployment, also in vaccine development. In the country, this was considered as a major Achilles heel, not only because of the geopolitical realities of the region, where we sit somewhere where we do not have ready access to vaccines which are being manufactured in the region. So Pakistan needs to become self-sufficient in terms of its own vaccine security for national purposes. What is the role of the Pakistan Academy of Sciences? It's an academy, and therefore, in moving forward as the premier academy of sciences, we felt that it has to play a key role in advocacy, convening, and the special projects that it should partner with national and international agencies. They don't do these projects itself, but it creates the enabling platform, as Dr. has tried to do with this meeting, and we did this work with this roundtable a few months ago in bringing people together to focus on certain problems. It could link science bodies that otherwise do not link. And one of those is really bringing together the three major bodies that look at this in countries: the Ministry of Science and Technology, the Higher Education Commission, and the Ministry of Health Services and Regulation, and potentially also the private sector, the industry. It is best for the EAS, we felt from that workshop, to focus on specific areas of work rather than try and do everything. So research into immunology or mechanistic research, pandemic preparedness, looking at vaccine hesitancy, factors that lead to inequity in terms of disease burden and response, and also indigenous approaches such as the use of our pharmaceuticals, herbal preparations, and indigenous research in this area we work on before. And just to make a final plug, that later on this year, perhaps around November, December, we will be holding another platform discussion at the Academy of Sciences on the role of nutrition in COVID-19 hopefully by the time this pandemic is behind us. Thank you very much for your attention, ladies and gentlemen, and I'd be very happy to answer questions you post. Thank you.
Thank you so much, Dr. Bhutta. That was really great. We are extremely grateful to you. We get the questions now or at the end of the session? Any question from the audience over here? Yes, please.